Good afternoon. I'm Carla Coleman, Director of Communications for New Salem Baptist Church in Columbus, Ohio. Thank you so much for joining us. Please remember to share with your friends and family. We have a lot of good information for you today. How much do you really know about the disease and how it disproportionately affects the Black community? Multiple myeloma, like many other diseases, impacts the Black community 2 to 3 times more than any other race or ethnicity. We have partnered with the Community of Caring Development Foundation, Amgen, ColumbusBlack.com, and Heal Collaborative. And I would like to thank our executive producer, Minister Brenda Troy from New Salem Baptist Church. We are here to bring you some valuable information on the disease, and as well as hear some personal stories from a patient, her physician, a patient advocate, and a policymaker. So thank you again. Today we have with us Dr. Yvonne Efebera, who's a professor of hematology and as well as an oncologist at the Ohio State University Comprehensive Cancer Center. Also, we have with us her patient, Marilyn Zimmerman, and we have Dr. William Hicks, who is a retired clinical professor at the Ohio State University. We also have a representative from Senator Craig's office, and his name is Alan Bruce, and he's going to give us a few remarks today before we get started with our discussion. So Alan, why don't you tell us a little bit about what's on your mind and how the senator is working in our favor here.
Yes, certainly. Good afternoon. And on behalf of Senator Herschel Craig, thank you so much for reaching out to our office and inviting us to this event. We're certainly excited to be a part of this event. And he sends his apologies that he couldn't be here today, but we did have time to make it out here today from the office. So anyway, I'm certainly here, very happy to hear and learn more about multiple myeloma. And also wanted to mention that because multiple myeloma has such a disparity on the Black communities of Ohio, we have put into legislation, or at least started the process, to make multiple myeloma awareness designated the month of March and recognized by the state. So we're really happy about that. Still working, drafting the legislation for that, but we are so excited to help spread awareness for this disease, as it is one of the contributing factors of the issues that it causes. So we're so happy to be here and happy that you have us on.
Wonderful. Thank you so much, Alan. We appreciate hearing from Senator Craig's office, and we appreciate you being on with us today. So now we're going to get started with our discussion. And one of the things that we wanted to know is, just what is multiple myeloma for those of you who don't know. And we have with us again, Dr. Efebera, who's going to really walk through just the things you need to know about the disease, as well as how it impacts the African-American community. So I'm going to throw this over to you, Dr. Efebera.
Thank you so much. Let's move on to the first slide, please. So, myeloma affect a lot of patients, predominantly, African-American, twice as many as Caucasian. My talk is, a short one for about 20 minutes. It's not enough to talk everything about myeloma, but I am going to do my best to break it down as simply as I can to make this, worthwhile. So we have come a long way with multiple myeloma. This was the first case in 1844 by Dr. Bench Jones. As you can see, this patient has broken bones and the sternum and the legs. They're mushy and fractured. And this is one of the symptoms we see, but a lot has improved over many, many, many years, and people don't look like this anymore. Next slide. So what is multiple myeloma? It is a blood cancer, and just like any blood cancers, they have cells that are involved, and in particular, the plasma cells for multiple myeloma. So plasma cells make up 2% of our cells in our bone marrow. And the function of the plasma cell is to improve or fight infection. Plasma cells produce this protein called immunoglobulin, or Ig. And the function of the Ig is to fight infection. When we have a cold or we have an infection, these immunoglobulins proliferate and help us heal. In multiple myeloma, these plasma cells become abnormal, and they make copies of these abnormal plasma cells, and hence the immunoglobulins are abnormal. And so one of the major risks of multiple myeloma is infection. In fact, patients may actually be in a remission and die of infection because of these immunoglobulins that tend not to function early on. And so with treatment, you get a rebound back of the immune function. So it is a blood cancer, and it's about 2% of all cancers, and it also represents about 17% of blood cancers. Lymphoma is the #1 blood cancer. So we have oncology cancer like breast, lung, prostate cancer, and colon cancer, which are the most common in the United States. And then you have the blood cancers, and lymphoma and multiple myeloma are the most common. It affects, patients, elderly patients. 10% are only less than 50%. So the majority are patients in their 60s. And it's not very uncommon, even though compared to breast cancer. So about 32,000 new cases are diagnosed in each year. And as we mentioned before, Blacks are twice as likely to have, multiple myeloma, and more so in males, just like you see in prostate cancer. A lot has evolved over the years, and while it is still not curable, now we actually call it chronic myeloma because of all the improvement we've had over the years. It is very treatable, and patients can be in remission for years and years, and then patients do live longer now. 20 years ago, the chance of a patient surviving for 5 years was like 50%. Now it's over 80%. So things have improved over the years. Next slide. So again, age, gender, and race are the impact here in multiple myeloma. Next slide. So in general, we don't know what the actual cause is in just like many cancers. But there are specific risks. Patients who are exposed to environmental exposures, like the atomic bomb survivors have a higher risk. Patients who have been in Vietnam, so Vietnam veterans have a 16% high risk of having multiple myeloma. Farmers who are exposed to pesticides, and if you have more than one risk factors like smoking and overweight, obesity, and then you've you're a farmer, the risk multiply. While we don't have any mutation gene yet, just like in breast cancer, 15% of patients have the gene mutation and 85% don't have any gene. But there's a family risk. If you have a father or mother, sister, and brother, what they call first-degree relative with multiple myeloma, the risk is about 3 to 4 times increase compared to the general population. And adding to that obesity and diseases like autoimmune, where your body produces antibodies that attack your own system. So those are slight increased risk of multiple myeloma. And so what do we see here? Patients have anemia. About 70% of patients who come to see us have anemia. These are one of the the symptoms. They have fatigue. And then bone pain, as you see here in this picture, these are called lesions. So these plasma cells deposit in the bones and cause lesions, and the bones can become brittle and lead to fractures. So over close to 70% of patients come with bone lesions or bone fractures. And the kidneys also get involved. These plasma cells deposit in kidneys and can cause abnormal kidney function, and 20% of patients may actually end up on dialysis. With early treatment, you can reverse that dialysis and get the kidneys to working back. The lesions can, release calcium, make the bones, brittle, and then release of calciums which can cause, confusion and also fatigue. So what do we do for the testing? When patients come to see us with suspected multiple myeloma, so the usual blood count, we check your white cell count, we check the kidneys, we check the urine to assess how much of the protein is being secreted through the urine. And we also, we can check actually how much of the protein is in the bloodstream, the myeloma protein. And the x-rays, just like I showed you before, those lesions from the skull all the way down to the legs, we do x-rays to see how much of these lesions are in your bones. And of course, because the bone marrow is the site where these plasma cells are produced, we do a bone marrow biopsy where we take a needle, go into the, your hip joint, and take a little sample from it and look under the microscope, just like I showed you with the first microscope, with the first slide, and see how much, cancer cells and plasma cells are there. These all put together help us to make, to diagnose the patient, assess the stage, and see what their risk factor. We look at chromosomes on the bone marrow biopsy to see what if this patient is a high risk or standard risk myeloma. That really helps us to tune our treatment for this patient. So again, I talked about the problems, the CRAB, so calcium, kidney, anemia, and bones. With the high calcium, patients can present with confusion, and that can affect also their heart with irregular heart rate. Kidney failure, patients end up on dialysis. Legs swollen because of a lot of protein, being secreted from the kidney, abnormal protein, anemia with, fatigue and shortness of breath, and of course the bone lesions with fractures. Next slide, please. So, once you've diagnosed a patient, the next treatment, next step is to treat them. You want to treat the patient to get them into a remission, at least close to a remission, and improve on their symptoms. So stop the production of the plasma cells, these abnormal plasma cells. Since 2015, we have had 7 new drugs, as you can see here. This is huge for a myeloma that's really not as common as breast cancer or prostate cancer. This is huge. And if you go on to the next slide, you can see all the drugs that have been approved and the combination of drugs that we use. I'm not going to go through all of them. You can see that, and you can request the slides. But using, cancer cells have a way of evading chemotherapy. And so combining 2 to 3 of these drugs so we can attack the cancer cells on different, aspects. So these drugs have different, what they call mechanism of actions. And we can combine one drug with a different mechanism and another drug with another mechanism so that we can attack the cancer cells on all front, ways that they try to evade the chemotherapy. So generally we use 3-drug regimen, and these drugs are really, really well tolerated. It's not like old drugs that we used to use before where patients will have nausea, vomiting. These are called novel therapies or targeted therapies that, symptoms are much, much less. We don't even give patients nausea medicine anymore with our initial treatment. That's how good these drugs are. And they're really, really well, tolerated. Next slide, please. And so our steps in treatment is first to treat the patient to reduce the burden of the disease. So what they call induction treatment. So give them 3-drug regimen that act in different pathways that work together. So for about, up to 6 months or 6 cycles. And then we do the next step in patients who are eligible for stem cell transplant, or in general, what you call bone marrow transplant, using their own stem cells. I'll show you slides later on how we collect the, the stem cells. So that would be the next step after the induction. We give them a high dose chemo and then do a bone marrow transplant. And then after that, do a maintenance, treatment where we give them a low dose chemotherapy to keep their disease in check. And it continues as long as the patient is tolerating it and the disease in check. We also give bone strengtheners to help improve on the bones. As I said, it affects the bones have become brittle, they're fractures, and this reduces the risk fractures. Next slides, please. So many patients the way we collect, stem cells is, after we've given patient, their initial treatment to get the disease under control, we give them shots to stimulate their bone marrow to produce a lot of baby cells, what we call stem cells. And then we collect those stem cells through the blood. So we, this machine is called an apheresis machine. So we have a line in one arm and an IV line in the other arm, or we put a line on the chest. So blood comes out from one line, it goes through this machine. The machine filters out the stem cells from the blood and puts it in a bag. And then, at the end, this is what the product looks like. So this is your stem cells in a bag. And then we freeze it. So in about 2 weeks later, about 10 to 2 weeks later, we admit the patient and we give them a really high dose chemo to destroy all the extra cancer cells. And that we don't usually see with our usual testing, but it also destroys the bone marrow, and that's why we collect the stem cells before we give them this chemo. And then a day or so later, after the high dose chemo, 2 days later, we give them back this stem cells, just like we would give a blood transfusion. And these stem cells will work their way over 2 weeks into the bone marrow and start producing normal cells and baby cells. So it's and then 3 months later, we start them on the maintenance therapy. So patients are in the hospital for about 2 weeks, 2.5 weeks during this process. But this can be done also as an outpatient when in the right setting. Next slide, please. Obviously, there are patients who are not eligible to get a stem cell transplant or bone marrow transplant, as many people call it. Because the main reasons are because, with the lungs, if the lungs are not working well, patients with COPD or on oxygen, or if they have heart problem, if their heart is not working well. So age is not a limiting factor. I've transplanted patients 75, 76 years old. So if you're strong and you're 75 years old, we do this. So, but there are some patients who are not eligible for the transplant because of that high dose chemo that we give. So we treat them the same way. We give them that induction treatment, but a longer course, for about up to a year, and then we do the maintenance and the bone strengthener. So now in the system, with transplant, we we're developing new ways of treating patients. And now the new kid on the block is this thing called CAR T, or chimeric antigen T cell, which I know most of you have heard of. It's been developed for blood cancers. There are several drugs out for lymphoma. What CAR T is using our own T cells. So we, our body, we have B cells, we have T cells. So T cells have proteins on their surface, and you can actually develop another protein called antigen that is specific for that protein, your own T cell. And so what we do in patients who have relapse disease and we cannot do a transplant, CAR T will be an option. So we collect their T cells just like you would do the stem cells that I showed you earlier, and it goes to a lab, and the lab develops the specific antigen for that specific T cell, for your own T cell. And this is what you call the CAR T. So your antigen is bound to the T cell, that protein. And then, it takes about 2 to 4 weeks to develop. And then they bring it back to the hospital, and you give the patient a little bit of chemo and infuse this, CAR T, just like a transfusion, with the goal that your CAR T, your own T cell, will recognize your own cancer and fight it. And a lot of products have been approved for lymphoma and leukemia. And even now the CAR T is going into the other cancers like melanoma and cervical cancer. So a lot of clinical trials are ongoing to look at other cancers. There are 2 product CAR Ts that are going to be approved this year for multiple myeloma, for relapse when the disease comes back after the initial treatment. And we're doing more and more trials to get CAR T into like the upfront setting in patients who cannot do transplant, and maybe patients who have high risk disease that maybe we can do transplant and then the CAR T to kind of, improve. And this is all through clinical trials that help to improve the survival of patients. And so, with all the clinical trials that we have done and all the new drugs that have been developed because of the clinical trials that have been done, we have improved the survival of patients. As you can see here, the chance of survival 20 years ago was 50%, the chance of someone with them. And now, since 2014, it's over 80%. This is our OSU data. This is going to be published, very soon. And you can see here, this is the line for the 2014, compared to this in, 1992 when we started doing transplant. So a lot has improved, and the 10-year survival is over 60%. And this was just a similar, data that was done in 2008. Next slide, please. So when we, do this, but just like mentioned before, Blacks do have a high risk, twice as many to die compared to a Caucasian, even with all the treatment. And why is that? Next slide, please. There are many, many factors, but the single most factor is inequality to access of care. If patients have equal access to care and get to, a doctor on time, the outcome is just as similar as a Caucasian. So lower socioeconomic status contributes to lower access to care. Obviously, there are other factors that contribute to this. And you can see that on this slide. So 27.6% of African American are below the poverty level compared to 15% of all races. So that's a huge factor, and we're doing things to improve on that. But and this is the single most common reason: inequality to access of care, and we need to improve on that. Next slide, please. Health related, I talked about lack of insurance due to poverty level, cost of drugs, and Ohio State has been working a lot with pharmaceutical companies to give care to patients. I treat patients without insurance. We don't tell patients to go away. I have many, many patients who don't have insurance that we give treatments to, and with the help of insurance and also the OSU, have access to helping, patients. And we treat a lot of patients who don't have insurance or who don't even have, we can help with that. Location of care, because some patients live 2 hours away or in an area where it takes 2 hours to get to a physician, to a local physician. But also provider related stereotype. We have implicit bias. We see a patient who comes in alone or is not dressed appropriately, and we have that in our head. Oh, this patient will probably not be able to go through transplant. Oh, this patient will not be able to get the 3 drugs that I want to give this patient. So the bias, or how the patient looks, how they speak, and the way we talk to patients, we need to talk to patient at a 6th grade level, explaining to them what multiple myeloma is, what the treatments are, what the side effects are. And that helps patient on a comfort level. And also patient related problems, attitude and beliefs. I have patients who come in and say, I don't want to get treatment now, God is going to heal me. And I tell patients, the same power that God gave the pastor to preach to you is the same power that God gave the physician to help heal patients and help with their treatment. And so, all of those, we need to work with patients to help them with their beliefs and their attitudes towards, physicians and how they want to get treated. And, and just listed here, African American patients tend to participate less in clinical trials, and I'll talk more about that later. And also get the most appropriate chemotherapy, and be referred to, a treatment center that has physicians that only see multiple myeloma. Local private physicians see all cancers, but in an academic center, there are physicians who only do lymphoma, who only do myeloma, who only do leukemia. And you can do a coordination of care. So that's what I do at OSU. I have patients who come to see me from their local physician, and local physicians and I talk, they can get treatment locally, but doing that coordination of care and working with that physician to give the best treatment to patient. Next slide, please. So when you give the same access and the treatment to patients, we have done that study. This is the OSU study here. There is no difference between African American and Caucasians, none whatsoever. You can see that. This was a previous study that was done. So if you have access to care and you give the right treatment, go through transplant, or intensify their treatment if they're not transplant, if you cannot do transplant because of other conditions, the outcome will be the same. So how do we reduce that, right? So healthcare, literacy and, talking to patients, removing our biases that we have on patients when we see them. Trust and communication is the most important thing between physician and patient. Removing that implicit bias, and patients, seek help early, be your own advocate. Bring someone with you when you come see the doctor. Don't keep your disease to yourself. Talk to your family member. You may not understand everything, but there will be a family member that will understand, that can read and then tell you. Bring someone with you when you see a doctor, and seek. You can seek a second opinion. Any doctor who gets upset when you want to seek a second opinion, you don't need to see that doctor again. I tell my patients it is okay to go see another physician. I even recommend the centers that they should go to see another physician, and then they can come back to me with the recommendations, and I send them my notes and everything, and I talk to them. And the most important thing is participation in clinical trials. This is the most important thing. This is the only way we can improve the outcome of patients with disease. Every treatment reacts differently to different patients and different groups of people. By clinical trials, we were able to show that transplant worked. By clinical trial, we were able to show that after transplant, doing what they call a maintenance, giving a small treatment continuously, was better than just not doing anything. This is how we found out, about, blood pressure medication, that certain blood pressure medication work well with African American patients. So I know there's a lot of bias about clinical trials because of the Tuskegee, study that was done many, many years ago. It is not like that anymore. Every clinical trial that is done has to be approved by the FDA and the institution in which the trial is done. It's called the Institutional Review Board, the IRB. It consists of doctors, it consists of non-doctors, it consists of nurses, it consists of ethicist people. So they all look at this at the trial, and they make recommendations. And even when the study opens, we have to report every 3 months on the outcome, how patients are doing, what are the side effects. And it's not, patients are not being guinea pig. So clinical trials are not like giving placebo or not giving, treatment at all. So what we're trying to find out is, are there added treatment that we can give in addition to the standard treatment that's already approved? Given the standard treatment versus giving the standard treatment and adding something that probably may help to improve the lengthen the way the length at which the disease stays in check, and improving the the survival. Obviously, there are studies that in patients who have used all the standard treatment, and there are drugs that that just got approved or are being studied for patients who have no other option, and to see if that drug really works. So sometimes we have to do a placebo versus the drug because we don't know if the drug works. And so that's necessary, but those are in cases where patients are have used all the standard treatment and there's no other option. It's either hospice or you try the drug. But in general, it's adding new drugs to standard treatment. So very, very, very important to participate in clinical trial. And Dr. Ms. Zimmerman is going to talk about her, experience with trials. And lastly, this last slide is really to talk about the COVID and how it affects multiple myeloma. Remember, I told you about the, these plasma cells and the protein, the immunoglobulin that helps fight infection. When you have, multiple myeloma, you lose that, especially in patients who have active disease and are not in, the disease is not controlled. Those are the worst. In general, cancer patients have a slightly higher risk of death, 8.3%. But in multiple myeloma, because of that immune function, abnormal immune function, the risk of death is 33%. 33%. And we just published a study on that on 650 patients who had multiple myeloma. 33%, it's even higher if you have active disease and getting, active treatments. So very, very important to get the COVID vaccine. Even if you don't have multiple myeloma, you probably know someone who does. But, for you to get that vaccine so you don't spread the virus to someone who may have multiple myeloma that you don't even know may have multiple myeloma. And these vaccines are actually, over 40,000 patients participated in this vaccine, and about 10 to 15% of African Americans were involved in this vaccine study. So it works. It's even better than the flu shot we get every year. So please take the vaccine so we can reduce the number of deaths, and especially in cancer patients. Next slide, please. So this is just the patient resources, and I think they're going to show that at the end of the slide presentations also, so that you can take note.
Thank you so much, Dr. Efebera. This was wonderful, great information. I learned a lot. So we can keep things going. We're not going to take any questions at this time. We're going to continue on with our other panelists. We'd like to hear from Marilyn Zimmerman, who is one of Dr. Efebera's patients, and learn something a little about her experience with all of what you just heard from Dr. Efebera. Ms. Zimmerman?
My name is Marilyn Zimmerman, and in July of 2011, I was getting slim and trim and was having severe pain in my left femur. And one morning, Sunday morning, my minister said to me, "If you lose any more weight, we will not be able to see you." I ended up in the emergency room that night, and the staff took x-rays and did lab work and referred me to my family practice physician and said that I needed to have a CAT scan and ultrasound. Well, with the ultrasound, they were ruling out a blood clot, and I was thankful there was no blood clot. The next morning, I had to have a CAT scan. And if I would have paid attention to the tech doing the CAT scan, I would have known something was wrong. I had had her children in school, and after she finished the procedure, her eyes were wide. Soon after, my family practice person had his nurse practitioner to call me to tell me, "Oh, you need to come in now for your appointment," or I was scheduled for another time. And I was not happy about that. And the next morning when I got up, I had a fear. So I called a dear friend of mine to ask her to come to the doctor with me. And that's when I found out I had multiple myeloma and was told that it was treatable, but not curable. We decided was going to get treated at the James, and then my journey began. I never say I have multiple myeloma. I say that I live with multiple myeloma, and it is a journey. On my first appointment to see Dr. Efebera, family and friends were with me because I was overwhelmed. It was Dr. Efebera explained that the levels of multiple myeloma and the prognosis, and she also let me know I had the highest level of stem cells that a myeloma patient could have. That week, I learned the terms bone marrow biopsy, skeletal survey, 24-hour urine collection. Soon after, we set up my for OSU and found out when we set up my chart that I was scheduled for my first chemo that week. I get emotional. I'm sorry. And we went through the chemotherapy and I had Valcade with a steroid. And probably about September or October, Dr. Afabera mentioned a clinical trial. And in that clinical trial, there were 3 steps, branches of the clinical trial. There was one with stem cell transplant, and then another one was with a stem cell transplant followed up by Revlimid. And the third one was the one that I was selected for, was the 2 stem cell transplants and Revlimid. People did everything for me that they could. Since my immune system was compromised, I could not go to the grocery store, and a very dear friend of mine went to the grocery store for me. We went through the stem cell transplant, and I cannot say more. You need to work with your family and friends to help you to decide when you are overwhelmed about clinical trials. That clinical trial for me, I feel, saved my life. That is why I'm still here. We went through, family came in, my sister came in, cousins from California came in because they did not like the way I sounded on the phone. I went through the stem cell transplant the first one was end of December of 2011. And the day of my stem cells transplant was December 31st, and it was a day after my late sister's birthday, and I call that my second birthday. My second birthday, I stayed in the hospital, I think about 14 days, and my second stem cell transplant, I was in the hospital 11 days. I feel that I would take Revlimid 3 weeks out of 4. And at that time, after a few years, I could not continue in the clinical trial because my blood count were so low. My white blood count was so low. If you were on a multiple myeloma journey, I'll say any blood cancer, any cancer journey, you need to share your journey and not be afraid to share your journey. Tell people what is available and let your physicians know your medical history. I found out my granddad had multiple myeloma and never knew that's what he had. Tell people what you know. For example, literature that is available. Let them know about copay assistance. The Revlimid is thousands of dollars, and I haven't had to pay anything for the Revlimid. Participate in educational events. I have attended the Hicks-Harris-Ferguson multiple myeloma symposium since 2012 and ended up on the committee. And the late Cheryl Boyce asked me to replace her as a volunteer for the Leukemia and Lymphoma Society. When people are impacted with a blood cancer, one of the best books you can get for them is Understanding Labs and Imaging Tests. That is a great book, so you can understand what's going on. And another book that we are talking about now is a pamphlet called Each New Day, Ideas for Coping with Blood Cancers. But please, please, please don't hide your disease. Have someone to walk you through. I had a conductor I call, she has multiple myeloma, and my cousin put me in touch with her. I appreciate having this opportunity to tell my story. Thank you.
Thank you so much.
And I just want to say briefly that Ms. Zimmerman actually continues on a lower dose of the Revlimid up till now. And she's in a remission almost 10 years from her first, her diagnosis. So, which is really, really wonderful.
That is wonderful. Oh, thank you. Oh, thank you so much for sharing that. And what a perfect message at the end. It's so important for people to know, not just having a great doctor with you, but the support that you need along the way is extremely important as well. And God bless you and your family. And good to see you here today, Ms. Zimmerman. You look awesome. And I'd like to now introduce Dr. Hicks, who's actually, she mentioned his symposium during her discussion. So her talks, her remarks. So why don't you take it from there, Dr. Hicks? She's already given you your cue.
First of all, thank you to the Lunch and Learn Committee for asking me to say a few words about Hicks-Harris-Ferguson Multiple Myeloma Symposium. Approximately 20 years ago, in about 1985, I met Cheryl Boyce, who was at that time the director of the Ohio Commission on Minority Health. And then 5 or so years later, about 1990, she gave me a call to tell me that she was diagnosed with multiple myeloma. So I then saw her and continued to work her up and actually sent her for her first bone marrow transplant. The thing that impressed the late Cheryl Boyce was that she didn't, even though this disease affected African Americans at a twice as frequently as Caucasian Americans, she wasn't seeing and communicating with African Americans regarding this disease, and that disturbed her. And she said, we need to try to do something to allow us to communicate better about this disease. And so for the next several years, we stewed about it, and we figured out, with the help of a lot of other people who we'll mention in the next few slides, we figured out that yes, we could do something about establishing a symposium for people with multiple myeloma and their caregivers to try to make this disease easier to tolerate. We'll go into some of the specifics of what the Hicks-Harris-Ferguson Multiple Myeloma Symposium has done over the years, but I just wanted to let you know that Cheryl Boyce, the late Cheryl Boyce, was a pioneer in her thinking about this. As members of the Hicks-Harris-Ferguson Planning Committee, we realized that we needed some faces for this disease. And so we established that there were 3 faces in our community that we wanted to be the face of our symposium. All of these individuals had multiple myeloma, and all of them actually succumbed to multiple myeloma. The first person is Mrs. Eleanor Hicks, who was my mother. And I'll just say this, you're talking about the improvement in care. My mother was diagnosed with multiple myeloma in early 1980, and she was gone in late 1981. So it just goes to show you the improvement in the the care that we provide for patients with multiple myeloma. My mother was an educator for many years, and she was the first lady of Mount Olivet Baptist Church. The Reverend Richard Harris was a wonderful gentleman who was indeed pastor of St. Paul AME Church in Zanesville and St. Mark's Church here in Columbus for many years. He also passed as a result of his multiple myeloma. His wife, Joanne, Mrs. Joanne Harris, is a member of our Hicks-Harris-Ferguson Planning Committee. Lastly, Mrs. Eugenia Ferguson is the mother of Mr. Ferguson, who's on our committee. She was an amazing lady. She was trained as a practical nurse and then had the gifts to be a singer who performed with the great bands throughout this country. She also was an individual who was a part of the Ohio Council of Churches care for elderly patients. So she had a giving heart. Again, she succumbed to her disease as well. So these three individuals are the faces of Hicks-Harris-Ferguson, which we honor today. The Hicks-Harris-Ferguson Multiple Myeloma Symposium has provided an opportunity to do several things. We can, and again, this was all part of what we thought folks with multiple myeloma needed to have to cope best with their disease, in addition to quality medical care. We wanted to connect them with other minority individuals and the broader multiple myeloma community. We wanted them, and this is incredibly important, as was mentioned by Dr. Efabera, to gain access to scientifically accurate information about the treatments, the clinical trials and research that are available. We wanted to allow them to be informed advocates for themselves, for their families, and for their communities, and to have, again, increased involvement and contributions to increasing research, because this is the only way we're going to make progress. This is why folks are living so much longer today than they did back in 1980. We wanted to make sure that we also provided links for primary health practitioners with experts and treatment facilities. Not all family practitioners are really up to date on multiple myeloma, and therefore we want to make sure that they are allowed to participate in the Hicks-Harris-Ferguson Multiple Myeloma Symposium to provide more continuing medical education in that regard. To do the things that I just mentioned, we have not done those by ourselves. We've had a lot of help along the road. We've had a lot of communication and collaboration with the Leukemia and Lymphoma Society. We've had a lot of help and collaboration with the Ohio State University. Actually, Dr. Efabera has been one of our speakers in the past. We've had expert lecturers from across Ohio and across the United States. The African American Episcopal Church has been also crucial in terms of its help, as has the Columbus Jewish Foundation, CareSource, the Ohio Herbal Clinic, and multiple supporting pharmaceutical companies. These are pharmaceutical companies primarily who are involved in research and care of patients with multiple myeloma. Even though these were the major contributors, there were other contributors over the past 10 or 11 years that have helped us along the way. I just want to say one other thing. Over the past 11 years, it's been really thought, and I think I'm prejudiced in this regard, that we've reached hundreds of patients with multiple myeloma and their caregivers. It's been described that the Hicks-Harris-Ferguson Multiple Myeloma Symposium is one of the largest minority oriented multiple myeloma specific events in the country. And a lot of what we've been able to do has been allowed or promoted by our planning committee. And the names of all of the folks who have been on our planning committee over the years are included in this slide. And as you can see, Marilyn Zimmerman is a member, as is Jerome Ferguson, the son of Mrs. Ferguson, one of our namesakes, and Mrs. Joanne Harris, who is the wife of Reverend Harris. So again, we've worked together for all these years, and we plan to continue to work strong and hard until this disease, which is now described as very treatable but not curable, is ultimately curable. We've had several virtual programs during the 2020 pandemic. We've discussed recent developments in multiple myeloma diagnosis and treatment via a conversation with Dr. Craig Cole, who's an assistant professor of oncology, hematology and oncology at Michigan State University. We've also had a discussion described as My Journey to Advocacy, given to us by Kimberly Anderson, who is the wife of an NFL football player with multiple myeloma, and she's also a radio show host. Last but not least, we have had a virtual program dealing with healthy soul food cooking for the holidays, promoted by Michelle Lights, registered dietitian and certified specialist in oncology nutrition. Over the past 10 years or so, or 11 years, we've provided gift cards and to patients and their families and caregivers. And again, sometimes our patients and families need groceries. And if we can provide some assistance to those folks, we were more than happy to do so. We plan in the fall of 2021 to have a virtual Hicks-Harris-Ferguson Multiple Myeloma Symposium conference. And so we are strongly moving in that direction. My hope is that we'll be able to do that. Just so that people understand that we are fiscally responsible, the Ohio Federation for Health Equity and Social Justice serves as our fiduciary agent. And we are very pleased with the fact that we have that group, that organization, to look after us from a fiscal standpoint. And Ronald Browder is, of course, a leader in that organization and looks after us. So these are the major things that I wanted to promote. Obviously, I could spend more time, excuse me, going over each program that we've done over the past 10 or 11 years, but that we wouldn't have enough time for that. But we want to encourage anybody with multiple myeloma or their caregiver to please participate in our Hicks-Harris-Ferguson Multiple Myeloma Symposium. And we will make sure that this information regarding these programs is available to anyone in our community, in our state, and nationally.
Thank you, Dr. Hicks. Appreciate your being able to join us today and provide this information. And has so much great information to share with everyone today. I'm going to just note that there's some extra resources here. So Dr. Efebera, do you mind just giving us some closing remarks, just things that you would like for people to take note of based on your presentation and your work in this area?
Yeah, thanks so much. It's been a pleasure, being here. And what I need to say that don't give up. Cancer is not a death sentence. And a lot has improved over the years, and people are living longer. In fact, people are living sometimes normal. Mrs. Boyce had 20 years of living with multiple myeloma. That is huge, and lots of new treatment. So be your own advocate, participate in clinical trials, and open up to tell your family and friends and have them come with you, and go to an academic center, see someone that specializes in multiple myeloma, and they can work with your local oncologist to treat this disease, and be open and get the COVID vaccine. So thank you.
I like that. Get the COVID vaccine. I like that at the end.
And Dr. Hicks wanted to say something. Yeah.
This thing, when we get together for our family reunions, we need to talk about our family history of health. Just as was mentioned by Ms. Zimmerman, that her, I believe she said her grandfather was found to have multiple myeloma. Many of us would indeed be benefited if we knew perhaps that we had that kind of history. The reason I say that is because we all know that that first degree relatives have a greater increased risk of developing multiple myeloma. And perhaps if you shared that with your doctor, he or she may be more likely to evaluate you for something called MGUS, which is a precursor for multiple myeloma. If Dr. Efabera wants to comment on that, please go ahead and do so. But that's one of the things that that might be discussed.
Excellent. Thank you. I think that was a great point, Dr. Hicks, and bringing back Dr. Efabera, that we need to know our family history and we need to share it. And there's people within your family who do know, and they need to share it as well.
Just one other thing, then I'll go away.
No way, no way.
I think clearly this is a disease that affects the older population, but it's starting to affect younger people, okay? And one of the concerns that researchers are having is this obesity thing, okay? More younger people are obese than were obese in the past. And that may have that may contribute significantly to the increased risk for younger patients. What do you think, Dr. Efabera?
We don't, have restrictions on diet, but obviously, if someone is overweight and they have multiple myeloma, one of the things we tell them is we have a nutritionist see them so that they can lose some weight to their appropriate level. We definitely don't want them to lose, especially if they getting ready for transplant. We don't want them to lose too much. But if they're their appropriate weight, obviously obesity contributes to so many cancers, breast cancer, colon cancer, and other cancers. I mean, it's a major, major risk factor. So, we do recommend, multivitamin to help patients with their immune system, but there's no, specific, diet that, we recommend. But eating like someone who has a heart condition, eating, increase your vegetables and exercise are really, really key to helping in any cancer that patient has.
So, Ms. Zimmerman, do you have anything you'd like to share before we end today?
My message to you is to be your advocate and read literature. Read literature.
Excellent. Yes, that's important. We must be our own medical advocates. No one, you have family members who may step in, but you have to be your own. You have to, share your voice. Let your physician know what's going on with you, what your questions are, what you're concerned, whatever you're having any anxiety about. You need to be as open to them as possible so they can do their job, and reach out to those who can support you as well. Thank you so much, everyone, for joining us today. I want to say that this was really wonderful information, and I wish you a wonderful remainder of your week. Stay healthy and stay safe. Bye-bye. Thank you, panelists.